This will be the antihypertensive pharmacology portion from Unit M. So we'll go ahead and get started with this. So when we talk about antihypertensives, hypertension is the most common condition leading to myocardial infarction, stroke, renal failure, and death. So essential hypertension is the most common type of hypertension and affects 95% of people with high blood pressure. The exact origin of essential hypertension is unknown. However, contributing factors may include hyperlipidemia, African American race, diabetes, aging, stress, excessive alcohol ingestion, smoking, obesity, and family history. So, genetics and lifestyle factors play a large part in essential hypertension. So 5% of hypertension cases are related to renal and endocrine disorders. So if it's related to some other disorder, if the reason you have hypertension is related to another disorder, it's because that is classified as secondary hypertension. So here's the things, we talked about this a little bit in Unit N. The things that regulate our blood pressure are the kidneys via the renin-angiotensin-aldosterone system, so that RAS system. I included some supplemental, a short snippet of like a YouTube video on the RAS system in Unit N and the supplemental information that helps explain that probably a little bit better than I did in class. So the RAS system is responsible for regulating our blood pressure. So let's watch this quick snippet as well.
When you're ready to begin treatment for chronic lymphocytic leukemia, Calquence helps you do the fighting, and you can...
The renin-angiotensin-aldosterone system, RAS, is a hormonal system that controls blood pressure. While baroreflex is a short-term response to sudden changes in blood pressure, RAS is responsible for long-term regulation. In the kidneys, within the walls of afferent arterioles, there are specialized cells producing pro-renin called juxtaglomerular cells. Upon activation by a drop in blood pressure, pro-renin is cleaved to form renin, which is released into the blood. Renin converts a plasma protein called angiotensinogen, produced by the liver, into angiotensin 1, a peptide of 10 amino acids. Angiotensin 1 is further converted into angiotensin 2, an 8 amino acid peptide, by the angiotensin converting enzyme, ACE, predominantly present in the lungs and kidneys. Angiotensin 2 is a hormone. It binds to angiotensin 2 receptors in tissues to exert various effects. It stimulates vasoconstriction in systemic arterioles. It promotes sodium reabsorption in proximal convoluted tubules of the kidneys. It induces the release of aldosterone from the adrenal cortex. Aldosterone promotes sodium and water retention in the kidneys. In the central nervous system, angiotensin 2 has several effects. It acts on the hypothalamus to stimulate thirst and encourage water intake. It induces the posterior pituitary to release antidiuretic hormone, which promotes water retention by the kidneys. It reduces the sensitivity of baroreceptor response to increased blood pressure, so that this response would not counteract the effect of RAS. All these actions lead to an increase in blood volume and blood pressure. Angiotensin 2 is short-lived with a half-life of 1 to 2 minutes. It is degraded into angiotensin 3 and 4, which have lesser effects. Overactive or inappropriately activated RAS is a cause for hypertension. RAS is a frequent target of antihypertensive drugs. ACE inhibitors and angiotensin receptor blockers are common treatment for hypertension.
Okay, so hopefully after watching that, the RAS system makes a little bit more sense, and why when we give a ARB or an ACE inhibitor, those actually work to effectively lower your blood pressure. So when we talk about regulators of blood pressure, we're talking about kidneys, catecholamines, baroreceptors in the aorta and carotid sinus. So when we talk about baroreceptors, those are those receptors inside the vessel walls that detect whether or not your blood pressure needs elevated or lowered based on all of those secretions of those hormones, and those live in the aorta and carotid sinus. So whenever you'll hear people in practice say, whenever someone's blood pressure is low, to trend them backwards, which means tilt them back, laying flat, and lay them on their head, and it essentially will increase their blood pressure. And that's because you're driving blood volume into those baroreceptors, into the aorta and carotid sinuses. So in ascension, yes, it's going to increase blood pressure, but it's not a long-term thing. All it's doing is detecting that you have more blood volume in that area, and it's increasing blood pressure temporarily. So that's how your baroreceptors work. They're detecting the volume of blood inside the vessel wall. Your let's see, vasomotor center in the medulla is also responsible for regulating blood pressure. And then we have hormones. So ADH, antidiuretic hormone, atrial natriuretic peptide, and your BNP, which is your brain natriuretic peptide. All of these things are regulators of blood pressure. So ADH is a hormone stimulated by the kidneys to conserve and retain water when there is a fluid volume deficit. So that tells your body to hang on or to excrete water, depending on what your body is sensing it needs. And so when there's fluid overload, ADH secretion is inhibited, and so that means the kidneys excrete more water. So there are physiologic factors that are also responsible for our blood pressure, including our diet, lifestyle factors, including excess saturated fat and carbs, alcohol, which increases renin secretion, so it has a direct impact on that ROS system. Obesity increases cardiac output, stroke volume, and your left ventricular filling. So cultural responses to antihypertensive agents. African Americans are more likely to develop hypertension at an earlier age. And let's see, Asian Americans as well are twice as sensitive as Caucasians to beta blockers and other antihypertensives. Often Asian Americans need a reduced dose of an antihypertensive agent. Native Americans also have a reduced or lower response to beta blockers. So these cultural sensitivities in these areas are required because they have altered responses to those drugs and that drug therapy. And then hypertension in older adults. Usually as people age, obviously they are at an increased risk if they have hypertension to have secondary issues from that, including stroke, MIs, and usually this is a long-term result of lifestyle factors that have compounded and led to hypertension. Let's see. However, the use of antihypertensive agents in the older adult can lead to unwanted side effects, as it can in anyone, but is usually more significant in the older adult because it can lead to like orthostatic hypotension if they're taking too much, or especially if they're malnourished or they're frail. So what are things we can do non-pharmacologically for hypertension? This includes stress reduction, exercise, restricting our salt intake, decreasing our alcohol consumption, and always encouraging smoking cessation. So those are all things we can do as far as lifestyle changes to control hypertension. And so let's talk about some diuretics. So diuretics promote sodium depletion, which decreases extracellular fluid volume. So you're flushing that extracellular fluid out, and usually when we do that, we're losing salt because salt lives in the extracellular fluid. So diuretics are the effective first-line drug for the treatment of mild hypertension. So hydrochlorothiazide is a thiazide diuretic. Furosemide, or otherwise known as Lasix, is your loop diuretic. So the combination of potassium wasting and potassium sparing diuretics. So when we talk about that potassium, we talk about we talked about in our unit in our fluid and electrolyte lecture about how when you give diuretics, there are certain diuretics that they do not spare electrolytes whenever we talk about them flushing out your system. And so there are certain diuretics that are potassium wasting and others that are potassium sparing. And so when we're giving those drugs, we need to be cognizant and aware of what's going on in that patient's diet and other drugs they might be taking, and so that we do not contribute to hyper or hypokalemia. So we'll get into those here in just a second when we get into specific drugs. And so a lot of the time, your thiazides will be in combination with other hypertensives like your ACE inhibitors, beta blockers, and your ARBs, or your angiotensin receptor blockers. So your sympatholytics are your beta adrenergic blockers. So remember back to our other lecture when we watched the video about your beta blockers, right? So your beta and your alpha receptors work on your vasoconstriction, they work on your lungs, and they work on your heart. So beta adrenergic blockers reduce cardiac output by diminishing the sympathetic nervous system response. And so in effect, sympatholytics are beta adrenergic, centrally acting alpha 2 agonists, and our alpha adrenergic blockers, adrenergic neuron blockers, and alpha and beta adrenergic blockers. So specifically in your pharmacology book, those tell you what each one of those drugs are. But those are also, as a class, those are known as sympatholytics. So we'll go through each one of these as we go here. So beta adrenergic blockers, so these are known as your generalized beta blockers. Remember, these end in LOL. So beta blockers are your metoprolol. These are non-selective beta blockers, so they inhibit your beta 1 and beta 2 response. Or your beta 1 and beta 2 receptors. So the propanolol, carvedilol, metoprolol, all of those end in that OL, have that OL ending. And then there are another class that are cardioselective, which are beta 1, which work specifically on that heart receptor, so that beta 1 receptor. So those are cardioselective. Ace-butylol, atenolol, betaxolol, metoprolol is cardioselective. So all of those work on your beta 1 receptor. Side effects of these, obviously, if you're overdosing, are hypotension, bradycardia, dizziness, can cause some insomnia, fatigue, depression, erectile dysfunction. Some can cause bronchospasm, depending on what that's targeting, if it's got some beta 2 influence on it. So when we talk about our centrally acting, we'll move on to our centrally acting alpha agonists. So alpha agonists decrease the sympathetic response from the brainstem to the vessels. So we're talking about vasculature. These are methyldopa, clonidine, and guanfacine. So these stimulate the alpha 2 receptor. Okay. So these work to decrease cardiac output, decrease your epinephrine, norepinephrine, and renin release. So that's that sympathetic response of those hormones being released in your body. So alpha 2 agonists decrease that response. And then also these increase vagus activity, so the vagus nerve. So methyldopa is contraindicated to liver function. When we talk about methyldopa, let's see what your book has to say about that exactly. Methyldopa was one of the first drugs widely used to control hypertension. In high doses, methyldopa and clonidine can cause sodium and water retention, and frequently these are administered with diuretics. We do not want to abruptly stop these drugs because it can result in rebound hypertension. Usually, we don't want to give methyldopa to patients with impaired liver function, because if they have increased liver enzymes on that lab work, we need to make sure that that's something that we're looking for. So let's move on to alpha adrenergic blockers. So alpha adrenergic receptor blockers result in vasodilation and decreased blood pressure. So these help maintain the renal blood flow rate. alpha blockers are used in treating hypertension in patients with lipid abnormalities, and they decrease your LDL, your low density lipoprotein, and they increase HDL, so good and bad cholesterols. So doxazosin, prazosin, terazosin, these are all examples of your alpha adrenergic blockers. So they block the alpha adrenergic receptor, they result in vasodilation. Some, again, effects of all of your blood pressure medications could essentially lead to hypotension. Headache, drowsiness, dizziness, nausea, nasal congestion, potentially on this one, edema and weight gain as well. So adrenergic neuron blockers are a potent antihypertensive that block norepinephrine release from the sympathetic nerve ending and causes a decrease in norepinephrine, resulting in a lowered blood pressure. So again, similar side effects as your other blood pressure meds: orthostatic hypertension, peripheral edema, dizziness, drowsiness, depression, erectile dysfunction, pseudo-Parkinsonism, so that's like Parkinson's-like symptoms. So moving to alpha-1, beta-1 adrenergic blockers. So this is like your labetalol. So these work on the alpha and the beta receptor. So it blocks those alpha-1 and beta-1 receptors, causing vasodilation, which decreases resistance to blood flow. So in essence, that's how we're lowering our blood pressure, by vasodilating. The effect on the alpha receptor is stronger than the effect on the beta receptor. So blood pressure is effectively lowered by vasodilating, and pulse rate is moderately decreased. By blocking your beta-1 receptor, it also decreases your AV contractility. So large doses of this can also block your beta-2 receptor. So a side effect of this could potentially be increasing your airway resistance. So patients who have severe asthma should not take large doses of metoprolol. So it's very contraindicated in patients who have asthma. Hypotension, bradycardia, paresthesia, depression, nasal congestion, nausea, and erectile dysfunction are all side effects of this. So when we talk about the clinical judgment of these, and we talk about the nursing aspect of these, when we're giving these medications, what we need to be doing is assessing that patient in the first place. Look at those baseline vital signs. If their blood pressure is already low, then maybe that's something we need to assess or hold that drug and contact our physician for further clarification. Maybe we need to look at our order parameters, and we need to be cognizant and aware of what our parameters are in order to be giving that medication, and if our blood pressure is at a therapeutic level or not. So we always want to make sure we have a medication history. We always want to make sure we have baseline vital signs before we're giving any kind of antihypertensive, which includes pulse rate, blood pressure, all of those things. So in order, and when we talk about generating solutions, like our goal, our expected outcome for this patient is that our administration of this drug, so the intervention of giving this medicine, effectively lowers that patient's blood pressure. So also, in addition to monitoring vitals, we also want to monitor lab results, including liver enzyme levels, depending on where the drug is metabolized, lab results, serum creatinines, all of those things. So if it is like an ACE inhibitor or an ARB, you would want to monitor your creatinine levels or your kidney levels, or your kidney numbers on lab work, because if it's working on the ROS system and our kidneys are impaired, then it could potentially have a decreased effect if our kidneys are not working effectively. We also don't want to abruptly stop any of these medications, and then also we always want to have a clear background of what they're taking as far as over-the-counter medications, because some things can interact with some of these blood pressure medications. Similarly, in alpha adrenergic blockers, these are all, for the most part, very similar with clinical judgment and our nursing process when we talk about beta blockers, alpha blockers. Another intervention we may want to do is we always want to have a baseline weight on these patients so that we can see if they are retaining fluid, since that could potentially be a side effect of some of these medications. So we always want to educate about drug therapy and always educate your patients to not abruptly stop these because it can cause rebound hypertension. So let's talk about this next class. So these are direct acting arteriolar vasodilators. So these do exactly what they say they do. So they dilate the vessels. So hydralazine and minoxidil. So they relax the smooth muscle of blood vessels, especially in the arteries, causing vasodilation. Again, if you give too much of these can cause hypotension, tachycardia, palpitations, headache, dizziness, edema. So those are the two direct acting vasodilators. Let's talk about your book mentions that nitroprusside or nitro is prescribed for an acute hypertensive emergency. It is a very potent vasodilator that rapidly decreases blood pressure and acts on both arterial and venous vessels. So angiotensin converting enzymes, so these are your ACE inhibitors. So when we talk about that ROS system, they are inhibiting the formation of angiotensin II and blocking the release of aldosterone. So what we're doing when we when we inhibit angiotensin II is a vasoconstrictor. So if we're blocking that action, then our vessels are not able to constrict, which would result in vasodilation, which lowers our blood pressure. And then when we block the release of aldosterone, aldosterone promotes sodium retention and potassium excretion. So when it's blocked, we are excreting sodium and retaining potassium. So we're having the opposite effect. These drugs cause little effect on your cardiac output or heart rate. They lower peripheral resistance, so they're dilating those blood vessels. Most of these are used in hypertension, and others can be used in heart failure. So benzapril, captopril, these are your prils. So look at the endings of these drugs. So if you see one of these on your test and it ends in PRIL, then that's an ACE inhibitor. A lot of times these people will have a dry cough. That's a very characteristic side effect of people on ACE inhibitors. Typically, African Americans and older adults do not respond as well to ACE inhibitors, but when taken in conjunction with a diuretic, it can actually lower their blood pressure. So often these are given in conjunction with a diuretic drug. Let's see. With side effects, these are, like I said, your non-productive cough or that dry cough is very characteristic of your ACE inhibitors, so that what they might call an ACE cough. So also in these patients where we're not flushing out potassium, we want to monitor for potassium retention. So hyperkalemia could potentially result here. We also want to monitor, this one is huge for angioedema. So angioedema is swelling of the face, tongue, lips, and mucous membranes. All of that, the larynx. It is rare, but it does occur from a hypersensitivity to the drug, and it could occur usually within hours to a week after the first dose. Every now and then you'll see somebody who's just started this drug that comes in and their faces and their lips are really swollen, and that's because they are developing angioedema because they have a sensitivity to this drug. So we want to make sure that we are educating patients on that and educating them on the signs and symptoms of angioedema, and also that they understand that a dry cough is pretty normal when they're taking a drug like this. So contraindicated, these are extremely contraindicated in pregnancy. Should not be given because they can cause harm to the fetus. reduces placental blood flow. Also, we want to make sure that we are, like I said, monitoring our potassium levels. And if they're given in conjunction with a potassium sparing, well, they should not be given in conjunction with a potassium sparing diuretic, because if we give anything, these are already causing us to retain potassium. So if we're giving anything else, like a potassium sparing diuretic that's causing more retained potassium, then that's going to lead to hyperkalemia, which essentially could also lead to lethal heart rhythms and other complications. And then also we want to monitor our diet for other things that could potentially hold potassium. So we'll talk about our ARBs, our angiotensin II receptor blockers. When we talk about ARBs, they are similar to ACE inhibitors in that they prevent the release of aldosterone. So these act on the ROS system again, and they block angiotensin II from angiotensin I receptors. So the difference between them is ACE inhibitors inhibit angiotensin converting enzyme into the formation. So ARBs cause vasodilation and decrease peripheral resistance. These usually do not have the side effects of like an ACE cough, so you won't usually see the dry cough with ARBs as you do with ACE inhibitors. So these are usually your sartan drugs. So your ARBs are like losartan, valsartan. So these all have that ending with sartan. So if you see this, you should know that an ARB is a sartan. So it's working on the ROS system. Usually these can be given in conjunction with some of your other diuretics as well. So direct renin inhibitors, aliskiren is one of the only ones that is common. So these bind with renin, which causes a reduction in angiotensin I and II and aldosterone. So again, it works on the ROS system of the kidneys. Side effects of these include dizziness, pharyngitis, hypotension, peripheral edema, hyperkalemia, diarrhea. So if it's working on that ROS system, it's potentially causing us to retain potassium and excrete sodium. Gout is another side effect of this. And then when we talk about calcium channel blockers, so calcium channel blockers slow the calcium channels found in the heart muscle, so that free calcium increases muscle contractility, peripheral resistance, and blood pressure. So when we talk about calcium channel blockers, it blocks the uptake of that calcium, resulting in decreased contractility, reduced resistance, and lowered blood pressure. Promotes vasodilation. So side effects of these include weakness, headache, dizziness. These are your verapamil, diltiazem. These don't usually have one specific ending, but you do see calcium channel blockers used quite frequently. So verapamil, diltiazem, amlodipine. A lot of times these can be given for like hypertensive emergencies. These can be given as IV drip drugs to help lower the heart rate, lower the blood pressure very effectively. So let's talk about a practice question. A patient is receiving a angiotensin II receptor blocker. Which does the nurse recognize as an angiotensin II receptor blocker? When we talk about angiotensin II receptor, we're talking about, let's go back through our information here. Those are those ARBs, ARB. So our ending on those are sartans. So valsartan should be our answer here. So we should, even if you don't know what the actual drug does, on your angiotensin II, those are your ARBs, ARB. So you should know with your ending in an ARB that sartan is your only option here. So this is, and you should also know by the endings of these that these are not the correct answer. So your OL is a beta blocker, your PRIL or your Pril is an ACE inhibitor, and so sartan is really, and this is a calcium channel blocker, so sartan is really the only option here. Okay, so that's the end of our Unit M pharmacology. I will post a Unit N pharmacology going over diuretics. Again, it's included in M and N, but I will go ahead and do an overview in it of diuretics in relation to fluid and electrolytes.